Hi guys, welcome. We're going to be doing chapters 25, 26, and 34, which covers cardiovascular, hematological, and musculoskeletal alterations. Please do check the announcements on Blackboard to see what you will need to do for chapters. These chapters will be on exam 7. And with that said, let's dive right in. So we're first going to look at chapter 25, which covers cardiovascular alterations. I do want you guys to review your anatomy and physiology, making sure that you point out the normal cardiac anatomy and how that all works for an infant, or shall I say a newborn. You also want to look at the normal hemodynamics. And when we go over the assessment of the child with a cardiovascular alteration, the main important thing I want you to pay attention to is, of course, the history and the physical exam. Of course, you know that you will inspect and auscultate, paying close attention for murmurs. I do want you to look at box 25-2, which classifies murmurs by grade. You do want to know the difference between grade 1 through grade 6. You also want to know how to take the blood pressures in a newborn and an infant and the differences that you will know from an adult or even an adolescent. When we look at diagnostic testing, note that an ECG, an echo, and an MRI are your most common ones that you will see. And in your text, starting on page 852, it goes over a couple of the diagnostic testing for cardiac alterations. I do want you to pay closer attention to pulse oximetry, the electrocardiogram, which is your ECG, Holter monitors, your echocardiogram, which is your echo, and cardiac catheterization. The last one I do want you to pay attention to is the MRI. You do also want to look at nursing considerations for the child undergoing a cardiac catheterization. You want to pay attention to the critically important steps that the nurse must monitor for, and these can be found in your text on page 855. You also want to look at the nursing alert, which covers children with latex allergies. And we will move right into congestive heart failure within the next slide. Before I do go on, I do want to mention a few things that I talked about that you want to pay attention to closely. A lot of heart defects will have a murmur. That is why I told you to pay close attention to the grades of a murmur. You want to know the differences between grades 1 through 6. If a child has a type 3 or a grade 3 murmur, you may hear a loud heart sound without a thrill. So you do want to note that. You also want to note that if the child is on medication, such as digoxin, and vomits that first dose or any dose reoccurring after that, do not administer another dose. You want to wait to the next scheduled time, whether it be every 8 hours or every 12 hours, to give the next dose. You do not want to repeat that dose even if the child has vomited the dose up. Also, if you are administering digoxin, one very important thing that you must check is the infant or newborn's pulse. It has to be above 100. And I know this is different from an adult. In an adult, we would say anything above 60 we can give. But if the newborn's heart rate is in the 60s or even anything under 100, that infant is going into cardiac arrest. So, for digoxin of the infant and newborn, we want those beats per minute to be above 100. You also want to note that a lot of children with heart defects will have a cardiac catheterization done. One sign that the nurse should look for is hypotension after that cardiac cath is done. This can be exhibited through cold, clammy skin and, of course, an increased heart rate in the infant or newborn. When teaching about a cardiac cath, you want to make sure that you, as the nurse, let the parents know that the child will return to the room or to the crib with a pressure dressing over that particular site. You also want to note that children may also have an echo done when the heart is suspected to have any congenital anomalies or defects. When explaining this to the child, you want to make sure that you're explaining it in their terms. Let them know that the tech, or wherever they're going, the ultrasound tech or the MRI tech, they will use a special wand that picks up sound that will be utilized to check their heart. They will not understand the medical jargon that you use, so you have to explain it in their terms on their level, depending on their age. Of course, you would not tell an adolescent. Now we will look at congestive heart failure, mainly pointing out in the incidence and etiology. Congenital heart defects are the most common causes of CHF in infants. You also want to look at the most common cause of CHF in infants, that it is congenital heart disease. You want to look at the most common ones. Those include your cardiomyopathy, your endocarditis, myocarditis, and so on and so forth. You do want to pay attention to those. Go ahead and review your pathophysiology. I do want you to pay closer attention to your clinical manifestations and as the treatment as well. Please look at box 25-3, which lists your clinical manifestations of congestive heart failure. You also want to look at the nursing alert in your text on page 858, which goes over serum potassium levels and digoxin administration. Please do note, administering digoxin, as we talked about in the last slide, that is listed as a family teaching box in your text on page 858. You do not have to know all of the medications that are currently used to treat CHF, but I do want you to know that main one, which is your digoxin. As stated before, please pay closer attention to your treatment regimens for your infants and newborns that have congestive heart failure or congenital heart defects, as well as your older children. And in particularly, we're looking at feedings, so pay close attention to those as well. You also want to go ahead and look at the planning and implementation for those children that are affected by congestive heart failure, as well as family teaching. Like I told you before, most of your nursing career will be focused on education, especially in pediatrics. Now we'll look more at the congenital heart defects, and this, as you can see, includes 5, atrial septal defect, ventricular septal defect, patent ductus arteriosus, atrioventricular septal defect, and truncus arteriosus. I do want you to go ahead and review all of those, noting the differences between them, specifically looking at the clinical manifestations, the diagnosis, and treatment. Of course, you would want to know what the actual defect is and what is happening, so you may have to review the pathophysiology as well. And this spans in your text from pages 864, and it goes through quite a few pages. I believe it goes all the way into 874 is when it completes. So do pay close attention to the differences between those 5, and I can correct myself and back up just a tad bit and say that it actually stops in your text on page 868. You do want to note the differences because following those we will go into defects with decreased pulmonary blood flow. So you have to know the differences between your congenital heart defects before we go into the deeper ones, which are your pulmonary blood flow, your arterial blood flow, and things of that nature. So when you're teaching parents nutrition for an infant that has acute heart failure, parents may need more teaching if they state that they will feed the infant every hour to make sure he or she eats enough. You want to note that if this infant is in acute heart failure, they are not eating constantly. Instead, they are eating less frequently because we are monitoring their fluid intake. Also, when caring for that same infant with heart failure, the nurse should be sure to educate the parents about increasing the feedings with added calories. That does not necessarily mean feed more frequently. That means to feed at the normal schedule, but we're going to add calories to it because the infant or newborn cannot take in as much fluid as the normal newborn. So when we look at teaching about congenital heart disease, you want to ensure parents know about the benefits of immunizations. When we look at ASD in particular, which is your atrial septal defect, you want to note that most infants do not need surgery to repair this defect if it is asymptomatic, which as you're going through this chapter, you will see that some, if not all, I would say the majority of them can be asymptomatic or they may be severe. So the spectrum is very large. But if the infant or newborn is asymptomatic, most oftentimes the pediatricians or neonatologists will keep an eye on the child to see if the defect corrects itself with age and time. Also note that this disorder, speaking on ASD, involves increased pulmonary blood flow. So this is when I say you have to go back and review your pathophysiology, what is actually going on in the heart to make this defect occur. When we look at VSD, if the child is given digoxin for this, explain to the parents that this is used to help prevent fluid accumulation in the lungs. More education would include performing palliative care until the infant is healthier. And one of those options would be something known as artery banding. You may find this in your text or you may not, but feel free to look it up and find out what it is. It is a very interesting and intricate process that they can do for the infant or newborn that has a ventricular septal defect. And lastly, when we look at the PDA, which is your most common one that you will see, your patent ductus arteriosus, and you may remember this from maternity. Upon assessment, you may find harsh, continuous, machine-like murmur under that left clavicle if you're listening. And like I told you before, as a new or novice nurse in the pediatric area, you may not be able to tell the difference between the grades of murmurs or even if the infant or newborn has a murmur. This too comes with time. So here I want you to go ahead and review defects with decreased pulmonary blood flow. Those do include pulmonary stenosis, tetralogy of Fallot, transposition of the great arteries, and tricuspid atresia. Same for as the other congenital heart defects, I do want you to pay close attention to the clinical manifestations, diagnosis, and treatment regimens. Of course, if you have to review the pathophysiology, please do that as well to actually understand what is going on in the heart as this defect is occurring. one of my most favorite pulmonary blood flow defects is tetralogy of Fallot. It is very interesting to see in person. If you've never seen it, please do try looking it up online to actually see if you can see what it is. It is a very interesting defect to witness in a newborn. Another good one to see is the transposition of the great arteries. So I do want you to pay attention to those and, of course, note the difference between them. Now looking at defects that obstruct left ventricular outflow, we have coarctation of the aorta, aortic stenosis, and hypoplastic left heart syndrome. That too is another condition that is very interesting to see and witness in a newborn or even an older child. I do want you to note the same things about the clinical manifestations, diagnosis, and the treatment for each of those, paying close attention to your hypoplastic left heart and your coarctation of the aorta. You do also want to note any family teaching for post-operative heart surgery, what needs to be done as far as activities, diet, wound care, any general considerations, as well as any medications that need to be taken. So when you are assessing a child with aortic stenosis, one may find that the child will have a narrowed pulse pressure, and that will be seen when you're taking the child's blood pressure. Now you want to look more at the acquired heart diseases, which is your acute rheumatic fever, Kawasaki's disease, and infective endocarditis. You may again have to review the pathophysiology for them, but do look at the clinical manifestations as well as the diagnosis and treatment. I do also want you to look at box 25-4 in your text on page 883, which lists the criteria for the diagnosis of initial attack of ARF. So, for a child that is diagnosed with rheumatic fever, the highest priority is, of course, promoting rest periods and bed rest as much as possible. For the child that is diagnosed, on the other hand, with Kawasaki's disease and is in the acute phase, the nurse should expect the doctor or physician to prescribe IVIG, Tylenol, and possibly aspirin. But note that aspirin can cause what? Ray's syndrome, which we will talk about in a little bit. But they may prescribe that as well for the child. For your child that has infective endocarditis, the nurse may find Roth spots on a child during the assessment. And I did not say raw as in R-A-W, I said Roth, R-O-T-H spots. If you do not know what those are, go ahead and look those up. But the nurse will find those on assessment for the child with infective endocarditis. You also want to note if the child needs surgery for any of the cardiac conditions. One condition that may be found afterwards, especially in your infant, is hypothermia. Before moving on to the rest of the cardiovascular alterations, I do want to point out a couple of boxes and nursing tips that I do want you guys to pay attention to. Box 25-6 in your text on page 886 goes over the principal diagnostic clinical criteria for Kawasaki's disease. I also want you to look at the nursing tip on page 887 in your text that goes over the administration of aspirin. Lastly, I want you to look at the nursing alerts on the same page 887, which goes over administration of warfarin or Coumadin and the administration of IVIG. Now we will look at hypertension. Of course, you all know what hypertension is, and I'm sure you've gone in depth in advanced med surg on this topic. So do please review the clinical manifestations and treatment, and then we will move on to heart transplantation. When we look at heart transplantation, I want you to look at the indications and transplant listing. I do want you to pay special attention to the post-transplant issues and, of course, family teaching. We won't go too much into the cardiac arrhythmias. I do just want you to review them, not so much memorizing or learning how to determine between them, because you will not see them on your exam, but I do want you to briefly review that information. Lastly, I want you to look over shock and the clinical manifestations, diagnosis, and treatment for those. I also want you to look at the kids want to know that is found in your text on page 897, which talks about life with a pacemaker. Lastly, I want you to look at the nursing alerts in your text on page 898 and 899, which go over severe hypotension, blood pressure in shock, and volume replacement in shock. And if you, as a nurse, see an adolescent who is obese and has hypertension, one of the main things you want to teach them is about healthy eating. Of course, when does our healthy eating habits start? In our younger years, our much, much younger years, such as our preschool, school age, even toddlerhood is when our good eating habits start. So we want to teach them to eat plenty of vegetables, especially if they have hypertension, and how to actually lower their blood pressure prior to putting them on any sort of medication. And with that said, that will complete chapter 25, which covers cardiovascular alterations. Please review the contents that we have talked about and discussed throughout these last few slides. If you have any questions or concerns, please feel free to let me know. Okay, now we are in chapter 26, which will review our hematological alterations. I do want you guys to go ahead and review your anatomy and physiology as always, making sure that you pay attention to the red blood cells, white blood cells, and platelets. Refresh yourself on any information that you may need in those sections. And now we will look at anemia. When we look at anemia, I do want you to understand what it actually is and what it is doing to the body. You can look at box 26-1 in your text on page 914, which goes over anemias classified according to their etiology. There are a few different types, so I do want you to know the differences between them. As you can see, there's iron deficiency anemia, sickle cell anemia, beta thalassemia major, and aplastic anemia. Again, while looking at these disorders, I do want you to pay attention to what they actually are. Refresh yourselves on any pathophysiology that you may need, and go ahead and look at the clinical manifestations, diagnosis, and treatment of these disorders. Again, I do want you to look at box 26-2, which goes over the compensatory mechanisms for anemia, as well as box 26-3 in your text on page 916, which goes over the signs and symptoms of anemia according to severity. You can look at chart or table 26-2, which goes over the common laboratory findings for anemia. Of course, I do not want you to know all of these. Just briefly look at them and see the differences between them. I also want you to look at box 26-4, which goes over the good dietary sources of iron. Of course, we want to always look at our family teaching because we will be educating the parents and caregivers for these children. Also, pay attention to the nursing alert, which goes over iron supplements in your text on page 919. When we look more closely at the sickle cell anemia, which starts on page 920, go ahead and review the clinical manifestations, of course, what the disease is and how it progresses, diagnostic testing, and of course, treatment. When we look at nursing alerts, look at the children with sickle cell anemia and the sequestrian crisis or the sickle cell trait as well. This can be found in your text on page 924. You also want to pay attention to the signs and symptoms of shock. You may review this, which is found in box 26-6. You may already know this information from Advanced Med Surg. Please pay attention to nursing management when we're looking at planning and also family teaching. And briefly, when we look at strokes, note that children do have strokes. Don't be misconstrued or let people tell you that children do not have strokes, because this is untrue. They do have strokes, but you want to know that ischemic strokes are more common than your hemorrhagic strokes. And we're going to briefly jump backwards, and I want to quickly review lead poisoning because this can be seen, and this is briefly talked about within the hematological chapter because of its effects on the blood system. When reviewing lead poisoning, if the lead levels are high, remember that the intervention of choice is, of course, you want to repeat the test within 2 days and, of course, prepare the child for chelation therapy. If that child is or does go on chelation therapy and is going home, the parents will need to know how to work the pump that the therapy is provided on. The parents will need further teaching if they think that the nurse will be the only one providing therapy to the child. Now, when we look at anemia, especially in a 4-month-old, that's in our newborn stage. This will usually be caused by inadequate intake of iron in the mother during late gestation. So if the mother isn't getting enough iron, this will usually lead to anemia in the newborn. When we look at aplastic anemia, a high nursing diagnosis priority is risk for injury. If the child experiences acute splenic sequestration, the treatment of choice, of course, is an emergent transfusion of blood, and this usually occurs with your children with sickle cell anemia. Lastly, when we look at an appropriate nursing diagnosis for a child with sickle cell anemia, or shall I say in sickle cell crisis, one would be acute pain related to the effects of sickling. I also want you guys to pay attention to the box 26-9 in your text, which talks about the criteria for severe aplastic anemia, and also box 26-8, going backwards a little bit, on page 929, which goes over the common toxic and pharmacologic causes of aplastic anemia. disorders of coagulation. There's 4 that will be talked about: hemophilia, von Willebrand's disease, immune thrombocytopenic purpura or ITP, and your disseminated intravascular coagulation or DIC. Again, I want you to note the difference on what they are and how they're manifested in the body. Go ahead and look at the clinical manifestations, your diagnosis, and treatment as well. I also want you to take a look at Table 26-5 in your text on page 933, which goes over classifying the severity of hemophilia A and B. You also want to take a look at the nursing alert on page 934 in your text, which goes over the child with hemophilia. Also note Table 26-7, types of von Willebrand's disease. That can be found in your text on page 937. And on page 938 in your text, you want to look at the nursing tip, which is care of the child experiencing a nosebleed. Looking more closely at ITP, you want to go ahead and look at box 26-11, which goes over viruses associated with ITP, and box 26-12, immunosuppressive medications used on ITP. These will be described in greater detail as you read through the treatment. When we look at DIC, this should be familiar to you guys. I'm sure you talked in depth about it within your maternity class, so just review this information. Of course, causes of your DIC and clinical manifestations of organ damage in DIC are good charts or boxes for you to pay attention to that can be found in your text on page 941. And once you've finished reviewing the treatment and nursing management for this disorder, this will complete chapter 26, which reviews hematological alterations. Here we will look at chapter 34, which goes over musculoskeletal alterations. This will be the last chapter within this lecture. Please go ahead and review your anatomy and physiology, and also review musculoskeletal injuries. These include your sports and recreation injuries as well as your soft tissue injuries. I do want you to pay closer attention to prevention of sports injuries found in Table 34-1 in your text on page 1298. You do want to note the differences between a sprain, strain, and a contusion. Please review the treatment, as this may be very familiar to you. It's rice, as well as looking for the actual definition of what rice stands for and what it actually means. This can be found in your text on page 1299. There's also box 34-1, which goes over rice in detail. When looking at overuse injuries, interventions to prevent these injuries are avoiding the causative activity for about 6 to 8 weeks if they can, applying ice to the injured area to reduce the inflammation, and linking the chain of communication in the disciplinary approach. Those are all interventions for those overuse injuries. We want to prevent those from happening. When we look at dislocations, you want to, of course, note the difference between a dislocation and a subluxation. You want to note the incidence and etiology, as well as your diagnosis and treatment, and of course, nursing management and family teaching. You'll always want to note the family teaching because we are going to be educating these caregivers quite often. When we look at fractures, note that this can be very in depth, and so I just mainly want you to know the differences between them. And figure 34-2 gives you a good illustration of the common childhood fractures, and those are the more, I could say, common, of course, ones that you would see in the child. So I do want you to know the differences between those if you see them, and if you read them on paper, you could decipher between which one was which. Of course, it goes over them in depth in your text on page 1302. You also want to look at the nursing alert on that same page, which talks about the damage of the epiphyseal growth plates. When we're looking at treatment regimens for our fractures, of course, it goes into many different options, from slings and splints to casts to internal fixations and rotations, and as well as traction. Please don't spend too much time in this area. Briefly graze over it, as I just want you to know the different modalities, treatment modalities that are available, not so much which each one does. I do want you to look at the need for calcium in the African American child with a fracture, which can be found in the ion on 1304 in your text. If the child does have a cast, I do want you to know the home care for that child, which can be found in box 34-2 in your text on 1305. The nursing alert in your text on page 1308 goes over the 6 P's to help assess with compartment syndrome. If you do not remember what compartment syndrome is, please review it in your text, as it is found in pages 1308 and 1309. Of course, we want to make sure that we're assessing our neuro status for our child, regardless of the age. So it kind of goes over an assessment with you in table 34-2 in your text on page 1310, as well as the physiological effects of immobilization and nursing interventions. Just briefly review that information. No need to actually harp on it. So, when we are looking at fractures, when assessing it, the nurse should look for the point of tenderness for the most reliable indicator that the child has had a fracture. If an infant is brought in and has a spiral fracture, you want to find the parents to possibly evaluate them for child abuse. Also, if the child has spinal surgery, you want to make sure you're checking those neuro statuses. One of those would be checking the legs for warmth and, of course, circulation. Okay, now we'll look at congenital disorders, one of which is your club foot. And we have talked about this disorder before, so I do just want you to review that information, as it should be very familiar to you, and what you should look for if the child has this issue. One treatment regimen that we may not have went in depth into is the Pavlik harness. Please do review that information, knowing what to do and how to do it if the patient, or shall I say the infant or newborn or child, is in one of those harnesses. When we look at muscular dystrophy, of course, review your incidence and etiology, what it actually is, your clinical manifestations, diagnosis, and treatment. Of course, we want to pay close attention to the family teaching, especially if this is a child. The parents must still care for the child, so they need to be educated on the disorder. So when we have a child with developmental dysplasia of the hip, like I said, the child may wear a Pavlik harness. You want to make sure that the parents are doing certain things, such as checking the areas behind the knees for redness and irritation, calling the doctor if the child is not able to move their legs or kick their legs, and changing the diaper without taking them out of the harness. A lot of parents believe that they have to take the child out of the harness to change the diaper. Not true. That is not what or how it was made. So make sure we're teaching them about that. Otherwise, the infant or newborn has no adequate time to heal. Alright, now looking at growth related disorders, we'll look at scoliosis, kyphosis, lordosis, and Legg-Calvé disease. For all of these, well, for the first three, they're involving the spinal column, so you do want to review the differences between them so that you can understand how the body is aligned when you're looking at a patient diagnosed with one or the other. Of course, review your clinical manifestations, diagnosis, and treatment. And there's actually option 1 and 2. Option 1, 2, and 3. So you do want to note the differences between those and why would one choose one over the other. You also want to look at the family teaching box, which goes over the child after spinal fusion for scoliosis. When looking at kyphosis, you want to do the same thing, review the pathophysiology if need be, the clinical manifestations, and we also want to look at diagnosis and treatment. Each of these will review your clinical manifestations, diagnosis, and treatment. It is up to you to review your pathophysiology if you need to do so. When we look at lordosis, you want to do the same thing, and note that these are relatively short, so you can go ahead and read through the whole thing without getting bored. Alright, and to finish up the chapter, we got two last additional musculoskeletal disorders, one of which is your osteogenesis imperfecta and your slip capital femoral epiphyses. You do want to go ahead and look at what they actually are, the clinical manifestations, and the treatment. For your slip capital femoral epiphyses, make sure you look at the diagnosis and treatment regimens as well. And with that said, that concludes chapter 34, which reviews musculoskeletal alterations. Please use this time to review all of the chapters within this lecture as well as the examples.